only problem here is that my 20-year-old is back from college, and he and his mother are going to, at some point, kill each other. So that's the downside. We're hoping and praying that they actually bring the students back to campus for the fall, because if not,
right.
we don't know what's going to happen.
Right. So the diagnosis there is you're normal.
Yeah, exactly.
It's a normal family dynamic.
No,
Hey, Tom, we're just starting to get some guests coming in now. Welcome, everybody.
Okay. Laura, I don't, or do I? Hang on a minute. Yeah, I do. Great. I don't have the ability to mute or unmute. I do see the chat window, so that's good. And I can see the question window.
Yeah, so I have an allow to talk button. Is that what you were saying in the past?
Yeah.
All right, well, let's say hi to some folks that are dialing in while we wait for our third panelists to call. Let me see if I can.
So I haven't quite figured out how to unmute everyone. I tried it and I couldn't get it to work on Zoom. It's probably a user error on my part.
So if I hit allow to talk and it says and unmute that person, and I'm not sure if it'll allow me unless
Yeah.
I'm trying to say hi to Brad Long now. I don't know if it's something on Brad's end or just the functionality of it, but Brad, welcome.
Hello there.
Hey. Are you Brad?
Yeah. Do y'all want us to stay muted while you're giving your presentation?
Presentation, that'd be great, but we wanted to say hello. If you could tell us where you're from, Brad.
Well, I'm out of Oklahoma City area. I work for a company called Datamax. That's out of Tallahassee, Florida. We're a company that does technology for law enforcement, criminal justice agencies.
Okay, excellent. Welcome.
Thanks so much, Brad. And I see we have Debbie Woodruff. Debbie, hello.
Hello, I work with Robert Crow at Amerisource Bergen.
Wonderful, welcome.
Hi, Debbie.
Hey, Bob.
Okay.
Your critique.
I see Barbara Law. Barbara, good afternoon.
Hi, how are you?
Good, how's it going?
Good.
Barbara, who are you with?
Trinity School.
Trinity School. That's where my wife teaches. Barbara, Tom Moran, how are you?
Hi, Tom, how are you? Good.
How did you hear about this webinar?
I received an email, so
Okay.
thought it was very interesting, and it's kind of where we are right now with our task force. So.
Okay, very good. Welcome.
Thank you.
That's funny. I thought I saw Nicolette chime in, but.
Did she, Nicolette, can you hear us?
I'm on.
Oh, there we go. There we go.
Right. All right, let me just get Nicolette on screen.
There we go.
There we are. Right. We are good. Okay, so it's time, guys. Let's go ahead and get started. I'm going to go ahead and start the recording now. Okay, yeah, we're recording. And I want to welcome everyone to the All Hazards Consortium Business Resiliency Virtual Discussion Series. This particular webinar, we're going to focus on the healthcare supply chain. And I think this is about our 6th or 7th one. So welcome back if you've been to some of our others. And if you're new, thanks so much for joining us. And we hope that you find this interesting and informative. I'm Laura Johnson. I'm the Director of Conferences and Events for All Hazards Consortium. As you may have just heard me say, we are recording this discussion today. And so we'll make that link available to all of the attendees that you can share with your colleagues and your peers. Also, we'd be happy to take any questions that you may have during the discussion. You have a Q&A menu item in your toolbar. So if you have a question, feel free to type it right in there. That'll go to all the panelists. And Tom, I'm going to pass the mic to you to say hello.
Okay. Welcome, everyone. Glad you all could take an hour or so, probably a little bit more, based on the content for today. Really happy to have our panelists on board. This is it's going to be a big topic, and we kept fairly free form because one of these speakers has a unique perspective, if you will, on many of the same issues, but very unique issues. So first, I want to thank Bob, Kelly, and Nicolette for joining us, and all of you for joining us as well. We hope this is the education. We are recording, as we said. We'll make it available, and really happy to jump into it. So you might hear reference to the SICE during the call today. So the SICE is a legal force in the private sector to protect private sector information so they can better share operational information with government and with each other in a secure way, meaning out of the reach of media, non-operational folks. So I just wanted to tee that up. If you hear a reference to that, you might understand what that is. That's what's made all this possible. The SICE allows people in private and sector and industry and government to come together and plan in a safe environment that's protected legally, and allows us to create solution discussions and things like that as we go forward. So for now, Laura, I'll turn it back over to you, and let's jump in.
Sure. Well, I'd like to welcome our three panelists today. We have Bob Crow with Amerisource Bergen Corporation, Nicolette Lewis-Saint with Healthcare Ready, and one of our board members, Kelly McKinney with NYU Langone Medical Center. So welcome to the three of you. Our first question today deals with the operational impacts of COVID. Can you please describe the impacts that the pandemic has had or is having on your company or organization and the current challenges you are facing? And Kelly, if I can start with you.
Sure. The coronavirus outbreak has had a profound impact on the operations of my organization. We're a large academic medical center located in Manhattan at East 34th Street and First Avenue is our main campus. We have 4 hospitals, one just down Second Avenue from here, another large hospital in Sunset Park, Brooklyn, and then NYU Winthrop, which is in Mineola, Long Island. So that is the healthcare side of my organization has been the most impacted. We have been in the epicenter of the outbreak, and we activated for this response on the 26th of January, Sunday the 26th of January, and we've really been running since that time. We were 24/7 in the early days of the outbreak when we were wading through that long tail of the response, and then as the outbreak gained its severity and we really started to see those patients, it really transformed us. We went from 4 hospitals that did do a range of services for dozens and dozens of different types of patients over the course of a day to really large respiratory critical care units, intensive care units filled with coronavirus patients. And to do that, we had to transform, our facilities. We had to convert our med-surg units and our operating rooms and our recovery rooms and our laboratory spaces and our conference rooms into coronavirus wards. And we had to do that in real time. So it was quite an intense 12 weeks, I would say. We are now sort of climbing down from the apex. We are now at a point where we're less than half of our beds are now occupied by coronavirus patients. And so we're beginning that rollback and we're trying to find our way back to the new normal. You know, we have a lot of, we have a long way to go to get back to where we were. We are, not-for-profit businesses, and my organization, there's an estimate that we lost upwards of $650 million over the course of the last 6 weeks, and so there's a real dynamic to try to get back to the normal course of business and build the business back, and so we're in that phase of the job now.
Kelly, is that due to the cancellation of the non-essential surgeries, most part?
Well, so yeah, I mean, you know, they call it elected surgeries, and elected surgeries are, you know, they're really, when you get right down to it, it really has to do with whether there's a medical necessity for a procedure or not. But yeah, the ORs are a huge driver of the business, and so the fact that the ORs were shuttered had a huge impact. But it really has to do with the nature of the patient. You know, the patients came in sick. They came in laboring to breathe, and a lot of them were intubated right away. We intubated 300 patients in the emergency department across the street in one day, and we had hundreds of patients on ventilators across our hospitals. Each of those patients is a huge operational burden. It's a 1-to-1 nurse-to-patient ratio. They don't have any visitors there. They don't have family there, so they rely on us for everything from not just patient care, but communication, sometimes even life decisions. And so, it had to do with the nature of the patient. But yeah, the ORs themselves are key, and they have started to open back up. But you know, there's a tremendous population out there that need to have surgeries done, whether it be for a cancer diagnosis or chronic pain or whatever it is, and so we have to get back to that.
Right. Thanks, Kelly. I appreciate that so much. Nikolai, why don't you tell us a little bit about Healthcare Ready and the operational impacts that the pandemic has had on your association?
Sure. I feel like I should go after Bob, but thank you for having me.
We can switch. It's okay. If you guys just want to switch.
Let's switch. It makes mine so much easier.
All right, Bob, I'm going to throw this one to you.
All right. Well, thank you. I appreciate that. But before I actually tackle the question, Laura, it might help a little bit if I could set it up a little bit and explain who AmerisourceBergen is to our group. AmerisourceBergen is made up of 27 unique businesses all across the spectrum of healthcare, but primarily today focusing on three of our main businesses. The Human Health Division here in the United States. Human Health here in the U.S. Is the primary pharma supplier for nearly 50% of the top hospital systems in the United States. More than 50% of the community oncology physicians' offices here in the United States, and more than 30% of all community pharmacies here in the United States. World Courier is next. They are an international business. They're the largest and most experienced specialty logistics provider in the world, with a fully GXP compliant transport and supply chain network. And most of their work is in clinical trials, another important term that we're dealing with here in COVID. And then lastly is our MWI Veterinary Supply Company, which is an international company as well. And they're a leading distributor of animal health products across the US and the UK, and both in the companion animal and the production animal markets. But I'm going to attack this question a little bit differently from an operational impact. Since we are a distributor of pharmaceuticals, we're in a position that we must keep the supply chain moving. There's no opportunity for us to fail, especially during this time. So when COVID hit, one of the first things that we really looked at was our associate safety. And it became paramount that our number one priority was to keep our frontline associates healthy so they can continue the pick, pack, and ship process, which is the lifeblood of our company. And we go back and lean on our core value, our number one core value. It's put people first and the rest will follow. One of the fears was people are not going to come to work. They're going to be afraid to come to work, especially if somebody falls ill. And unfortunately, we've had that. We've had associates fall ill across our network, and that was a big challenge for us. But some of the things that I'll talk about later put us in a position where that did not impact us greatly to this point. Being a pharmaceutical distributor, unfortunately, we at AmerisourceBergen, we're not a primary player in the PPE portion of the business. We strictly focus on the pharmaceuticals. So not only do we not have it, we're one of those companies that are out there searching to find it. So that's been a challenge for us. And our group has been very, very good at being able to source from many different areas. But moving the majority of our workforce remote was another huge challenge, just like it was for everybody else to do that. We are a person-to-person industry, a person-to-person business. Our distribution centers, of course, cannot work remotely. They're still working in the business, in the facilities, and getting the products out. But the rest of the support functions and our other businesses getting moved off to remote work from home has had huge impact to the operation. Next, I wanted to just speak briefly on strain to the supply chain. And Nicolette, hopefully I'm not stealing any of your thunder as well. You gave me the opportunity to go first, so if I'm stealing your thunder, just a couple stats that I wanted to call out. Here at AmerisourceBergen, on a daily basis, we distribute between 4 and 5 million lines per day. What a line is in an order, if you might be a hospital or a pharmacy, and you place an order for 10 items, 5 bottles of 1,000 count lisinopril, that is one line. So any order can range anywhere from 1 line to 100 lines. But on an average day, we do between 4 and 5 million lines. On March 12th, we picked 4.3 million lines. On March 15th, we picked nearly 6.5 million lines. So within a week's time, we almost doubled, not quite doubled, but almost doubled our normal line pick as to that was when the initial when the initial buying started to take place, when people were talking about stay-at-home orders and shutting down. So, you know, along with the toilet paper and the paper towels and the Lysol spray, well, pharmaceuticals went through that same process as well. So we saw that huge strain on the supply chain. Now, it wasn't even so much of that. There was inventory there. We had the ability to pick it. Normally, we may send out 13 trucks a night, tractor trailer trucks a night from a distribution center. Adding that additional 2.5 million lines, we had to go out and find additional trucks to get on board so we could actually move that product from our locations out to our cross docks or our forward docks and then onto our companies. Hydroxychloroquine, everybody's familiar with that. We saw a 1,130% demand increase, which is almost 6 months worth of that drug just in 1 month. Albuterol inhalers saw a 390% demand and increase between the end of February and the end of March. That equates to 2.3 months worth of inventory, all in 1 month being demanded from the hospitals and pharmacies across the United States. And then lastly, I'll wrap up this question here. Our ability to move products internationally. Again, World Courier is primarily a clinical trial business. So those of you that are in the industry understand how that process works, and that those products and those product lines have to continue to move. They can't wait. They can't be stopped. They have to continue to move. And we started seeing border closures back in the early parts of COVID-19 across Europe, when countries were closing down their borders. Nobody's coming in, nobody's going out. We had to circumvent that. We had to come up with ways and opportunities to get through and get past those border closures. But primarily, that business moves via air cargo. And most of that is on commercial airlines. And we all know the situation of commercial airlines right now, of how few flights there are. And our team's having to come up with other ways to get product from point A to point B in a matter of 24 hours to 36 hours tops. Was a huge impact to the operations, and our teams did a great job of working around some of those impacts. So I'll stop right there, Laura, and send it back to you.
Yeah, I appreciate that, Bob. Okay, Nicolette. Tell us about
That-
Healthcare Ready. Yeah.
That was great. So much faster. Thank you, Bob. Yes, so Healthcare Ready is a national nonprofit organization that's actually founded to serve as a connector of the end-to-end health supply chain. So our job is less about holding the assets, moving the assets, but rather doing the work of supporting our partners like Bob and ABC as they are doing the work of what we call continuity. So as Bob said, it's a no-fail mission. And what we have to make sure of is that in these times of crisis, it could actually be any part of the system that sees a vulnerability, but we need to make sure that whether it is the international logistics and a customs issue, or it's a surging in production and being able to actually get a better picture of demand from the hospital side to make sure that production of product is being surged in the right way, or assistance from government to be able to do everything from deal with the reentry issue at the last mile, as we all often talk about, or an actual coordination issue across the interagency to be able to make sure that emergency management and public health are synced up on these response issues. Our job is to be that connective tissue. So we are making sure that across the private sector, at every step of the supply chain, that we have those proper conduits and relationships, that we can do the work of maintaining sufficient visibility on operations, that if there is a challenge or a potential disruption, whether it be upstream or downstream, that we're able to identify those and in partnerships with our partners across the supply chain, like Bob and others, we're able to resolve those as quickly as possible. So I think for us, it's the obvious. It's everything that's been listed. The one thing, just looking at the speaker breadth that I'll try to focus on is manufacturing. You know, as Bob said, ABC does not focus on PPE and what we call medical surgical, med-surg supply chain, but there are other partners that we work with that do. And when it comes to understanding the availability of product, you've got a few things, and this is something that is a challenge on both sides of the supply chain, whether it be medical, surgical, or pharmaceutical. There's a demand, and then there is increased ordering because there's panic about the availability of product. And both of those constrain the system. There's real demand that is actually legitimately straining the system because we have an unexpected event that is surging the need. But then there is also kind of what we call the panic orders, and trying to make sure that available product is going where there is legitimate need is something that does require that type of continuity, but also making sure that we're doing the work of understanding not just legitimate need, but understanding how to anticipate the surges in cases, where those cases will be, and how that should be impacting what's happening upstream. So when you're thinking about, you know, how orders go, how orders are fulfilled, or how we actually do the work of getting a full picture of what the supply chain capacity is, it's based off of what we call historic demand. At this point in time, this picture, how much would we normally have? Or for this type of an event or what have you, how much of X would we need? And when you're dealing with a historic event, you need to have that type of information flow so that people can build a cleaner picture of what will be required. So we've been doing a lot of work in that side. And then the other part of this is we've been coordinating with our federal partners, and some of us being in a remote posture, some of us being in person, some of us having a hybrid. Coordination is hard enough when everyone is in the same place. It's difficult, even more so when we're all virtual, or some of us are virtual, and trying to respond to the dynamics that we see both at the federal and the state level have also been a significant operational change for us.
Thanks, Nicolette. So do you have data analysts on your staff?
Yes, so we do. We have normally between 11 and 15 people on staff. We have a surge model, so when we activate, we increase our staff size. So we're around 40, 45 right now.
Okay, great. Thanks so much. All right, we're going to move on to the second question here, which and you guys talked to this a little bit, but this focuses on initiatives and how you've addressed the operational issues that the pandemic has caused since the outbreak. Kelly, for example, you talked about converting some of the rooms to make it meet the functions that you need. Are there any other things going on at the medical center that have changed, or can you speak to initiatives that you and your team have been thinking about or doing since the outbreak?
So, you know, so we're emergency management. We're the overlay of coordination that is charged with enabling, you know, effectiveness in the crisis. And you know, this is a very hyper functional organization. It is filled with the smartest people in the world, and they are. It's very demanding. It's very data driven. It's very high tech, and it works exceedingly well on a normal day. But some of those processes break down in a disaster, and we're really here to reconnect the organization together in real time and speed the up tempo, right? Instead of the enterprise making strategic decisions that get vetted and developed and worked and then executed at a tactical level, you know, by nursing or by scientists in a research lab or by a professor in a classroom, you know, those decisions have to be made and executed in hours. And you know, one of the key terms that grew out of this incident was pivot. We use the term pivot on a daily basis. We have workflows. We have clinical workflows that we use for patient care that involve everything from how the patient is treated and where the patient is located, all the way to how the clinician protects themselves. And so those workflows were transformed in real time by a lot of things, but primarily by our understanding of the virus itself and what the transmissibility of the virus was, what the precautions were needed to protect people. And so, you know, we have developed and perfected those workflows over long periods of time, and we just broke them and rebuilt them day after day after day. And that process became ongoing, but it's difficult, right? It's difficult in the midst of chaos when there's chaos around you and actually chaos in your own mind. It's difficult to message that and clearly communicate changes and the justification for changes and the expectations about changes in the midst of a crisis. But that's what we did, and we did that through a number of interdepartmental working groups. One of our main working groups, and we started it very early on, was what we call the asset management group, which is really all of the stakeholders around supplies, you know, N95s and pharmaceuticals and equipment, clinical equipment, and all of the things we need for patient care. And you know, we met every single day for 110 days. But basically, it connected that organization together in real time. So the idea was we needed to identify that need immediately. We needed to surface that need to the highest levels and understand, is that something we need to act on? Are there approvals? Are there stakeholders that need to weigh in? And are we going to go and source, and are we going to go procure, and how are we going to do that? Are we going to beg? Are we going to borrow? Are we going to steal it? What are we going to do? How are we going to get that in-house? And basically, that's what it was. There was nothing that was going to stand between us and getting what we needed to treat these patients. So there were a number of initiatives around that. I mean, facilities had a working group to really transform. We had hard hats running up and down the hallways, you know, building out rooms for testing centers and for staff beds. And we had our MCIT group, which was basically enabling those new workflows in our Epic system and our Epic patient record system. You know, it's all, these days hospitals are really driven by these electronic medical record systems, and ours is called Epic. And those workflows, we almost all of them are in Epic so that we can, it really drives the processes. So all kinds of initiatives, they were all, most of them were convened by us out of the Emergency Operations Center. We met on a daily basis, and we basically drove what we call incident operations that way throughout the crisis.
All right, Kelly, thank you so much. And Bob, to steal a word that Kelly used, how did you guys pivot at America Bergen? What initiatives did you have to take to meet the demand of the healthcare supply you were being asked about?
Well, from a product perspective, much of the product was in the supply chain. It's just a matter of getting it to us so we could get it out. And today's pharmaceutical supply chain is designed as just in time delivery. Product in our building, it does not sit very long. It's right back out again. So that was an initial challenge. There was just some slowdown of getting that product from point A to point B and then eventually on to point C. So that was not necessarily a problem. And one of the things that we do and most of the major distributors do in situations like this, our products immediately go on allocation. And some people will, that's a bad word. Well, it's not really a bad word in per se. It's not to prevent people from getting their orders. It's so that everybody can get their orders. So instead of allowing one hospital system to order 10,000 units, because they might be able to have the ability to store that, we're going to somewhat, hold them back and make sure that everybody gets that fair, equitable distribution. Which we feel is very important. So there was a lot of that in the beginning. Over time now, we are seeing there are some issues with some of the pharmaceuticals. It just is when you have some of like the hydroxychloroquine was a malarial drug. Malaria is not a real big deal here in the United States. So there was not a lot of that available. I don't want to say fortunately, unfortunately, I wish it was the cure, but fortunately it turned out that demand has somewhat died off, and now there's demand of another drug. So we'll see the same thing with that as that goes. But again, I'm sorry, circling back to the initial issue with associate safety. How do we keep our associates safe in our building when they're here? So the health screening and the temperature check process, simple, right? Just check somebody's temperature before they come into work. If they have one, send them home. If they don't, well, let them come in. Well, those of you that are doing it realize there's a lot more to it than that. Do you do it inside the building? Do you do it outside the building? Well, let them come in the building. They're already here, so they may make other people sick before you even get a chance to take their temperature. In Southern California last week, there was record heat. So people will get out of their car and they walk across the hot macadam parking lot and they walk in the door and somebody takes their temperature, they have a fever. So, well, no, they really didn't. They're just a little overly warm.
Wow.
Across the parking lot and soaking up all those rays bouncing off the macadam. Whereas in the Northeast, we had almost record cold. So everybody's coming in with their wool cap on and their coats. They get their temperature taken. Oh, you have a fever. You have to go home. Well, not really. They just had a knit cap on for the last 20 minutes while they were commuting to work. So, we had some issues around that and worked through those. Again, so we can provide the safest situation for our associates. In a drug distribution, in a licensed drug distribution facility, we're bound by PDMA housekeeping requirements. We have a very robust housekeeping program. But COVID-19 took that program to a new level. Looking at, how do you clean these surfaces and make sure these surfaces are clean for our associates to use and to work with. So the introduction of the brew tabs and the shock waves and the electrostatic sprayers, developing new processes there where we have cleaning staff that comes in routinely, but now we're doing the electrostatic spraying 3 times per day. Which we're stopping operations, so we're allowing them to come through with the sprayers and spray down the entire building 3 times a day. Should we have a positive case, which unfortunately we've had, we've developed some really robust deep cleaning processes using ServPro, where we'll actually close the facility down and bring ServPro in for a deep clean, let the facility rest, and bring ServPro in for the deep cleaning and let it rest again before we actually resume operations. So. Looking at the cleaning processes were huge initiatives for our operation. And then going back to our IT, I have to give a shout out to our IT folks. They moved 70%, over 70% of 22,000 associates to work from home in less than 2 weeks. We have 27 businesses across the Bergen in 473 locations in 54 countries around the world. Prior to COVID-19, 5,000 routinely worked remotely, 5,000. Within 2 weeks of our initiative or our work from home directive, our IT folks moved 12,000 associates to remote work, which included 8 call center operations, completely going from in-person at their cube or at their desk working off of soft phones and desktops to remote work, which was an absolutely incredible job by that group. And again, I have to give them a shout out. Of course, we had our BC plans and they were designed for these, including pandemic. But they were really designed to shut down one facility and move that work to another facility, or maybe have to split it up to 2 facilities. But really, and I think most people would have to be honest, I don't know that any of us ever expected to have to shut down every bit of our operation and move it remotely at the same time. So those were just some of the things that we've accomplished over the last few weeks that have really been able to keep us going at really a pace that has been uninterrupted.
Thanks, Bob. Nicolette, I'm going to ask you if you have any initiatives you want to talk about.
Sure. I'll be very quick. I know there are other questions you want to tackle. A couple of things that we've done. We actually moved the bulk of our team to a remote posture in early March. So we had moved about 85% of our team into a virtual posture, probably about 3 weeks before most of our colleagues in the space. And that was in part because we needed to consider preservation of staff as a key part of our response. Our staff are fairly specialized and have been trained in what they do. And so the idea of selfishly making sure that we had enough of a rotation so that if someone were to become infected or go down, we had enough capacity across our team was an important consideration for us. So we actually shifted early. Our RX Open tool has actually, for the first time ever, been turned on for the entire nation. So we're reporting right now on 2 facility types, the status of pharmacies and dialysis centers for all of the US and US territories, which is new for us. But also to Bob's point about, our pandemic plans, honestly, we planned for pandemics, but we have spent as an organization significantly less time on med surge than we have pharmaceuticals. And so we kind of said we'd help out, but there are other organizations that we frankly thought would have been more in the lead on this, and we found ourselves quite in the lead on this. So that's been an adjustment for us as well, but also thinking through all of the nation at the same time in terms of how to determine the areas of critical need. And so that as a response posture has been significantly different for us also.
Okay, thanks, Nicolette. We're going to go ahead to partnerships. And Bob, let me start with you on this one. Can you tell us about some partnerships that you had to make since the outbreak, or others that you had in place that were important for you to use to meet your mission?
I think most of them were really in place. Starting out with the states and the individual EMAs, emergency management agencies, and their private sector programs. They're huge. Getting information about who we are and how we operate, and getting those groups to better understand pharmaceutical distribution in their individual states, and how they can support us and we can support them, as well as Department of Health. So again, they can really understand how the process is, how the process works. The relationships at the federal government with FEMA and the NBEOC was there in individual regions. We make it a point to try to have that direct relationship with the individual regions. Again, getting into the region, getting a little bit closer in that more personal relationship or partnership, not just with Washington or at the top level at the NBEOC, and which turned around. We've worked with FEMA recently in 2 huge initiatives. We were part of the hydroxychloroquine distribution initiative, And we are part of the most recent initiative with FEMA. Began 2 weeks ago. I'm sure most of you are kind of familiar with what that is, the remdesivir process. So that is, another one of the initiatives that we're part of, that we teamed up with FEMA and now with the states as the states are getting more involved in that. So it helps to have those relationships there. Industry-wise, I mean, I'm relatively a newcomer to the All Hazards Consortium here, so I appreciate that and the SICE. It's great opportunities to meet others and to make contacts, because you never know when you're going to need them. At HDA, we're a member of HDA. HDA now has the Pharmaceutical Cargo Security Coalition. Some of you might be familiar with that, some of you might not be. But there's a guy in there that runs that. Everybody says everybody has a guy. Well, that's my guy. He's my guy. And again, I could tell you stories, but we don't have enough time. But that's the guy. If you need to know a guy, that's the guy. Reach out to me, and I'll let you know who that guy is. And of course, I can't let out Nicolette and Healthcare Ready.
Right on.
Hey, this isn't a paid advertisement, but that's probably, Healthcare Ready is probably the best relationship that I've had in my years here at AmerisourceBergen in doing this. And this even goes back before Nicolette, back to her predecessors, Emily and, I knew I was going to Aaron, back to Aaron's days. And if those of you who are on the call are not familiar with Healthcare Ready and you're in the healthcare world, make it a point to do that. And then lastly, I never thought I'd have a relationship with WHO, but COVID required us to develop a relationship with the World Health Organization. I never expected that. And they actually helped deliver when we were having our border issues in Europe. They were the ones who helped deliver us the answers to get across those borders to help those clinical trials continue to move.
Very good, Bob. Okay, thank you so much. And I'd like to thank Bob because we found him because he was an attendee at one of our previous virtual discussions, and we hunted you down, Bob. Okay, Nicolette, tell us about some key partnerships that you've used over the past 7-8 weeks.
Sure. So as a public-private partnership, our job is partnerships. So one of the things that is really important for us and really something that we enjoy is that we do maintain a lot of partnerships. We like our partners. We like reaching out to them. Unfortunately, we only reach out to them this much when things are this bad and stressful. But having relationships and having partners like Bob and AmerisourceBergen and Cardinal Health and McKesson, but also those trade associations that are across the supply chain, because one of the things that we have to remember when we're dealing with an event of this size is that you can't just fixate on one or two companies to be the solution for all of the entire system, right? So you can strain the company if you don't actually focus on the sector and not just a company. And so we make sure that part of our job is making sure that we are balancing what we send to ABC versus what we send to HDA as it pertains to requests from the government or other things. Our partnerships with the government are very important for us, federal, state, and local. And that is something that we continue to maintain. I would say as it relates to new partnerships, on the newer side, there are always new patient groups that are emerging. And we do work really hard to make sure that we're connected to them. There are a few reasons for that. One is it prevents us from having to deconflict requests that come to, for example, FEMA regions or ASPR regions for products from patient associations or patient groups, as well as kind of some of those smaller networks. So it gives us the ability to figure out what that real need is, but it also gives us some visibility on what the specific challenges are for specific populations that we're focused on that might have unique medical needs. And so when it comes to the supply chain, it's not enough for us to just focus on COVID. We also have to make sure that other things are moving and chronic patients are getting their care and all of that. And that's what helps us get that visibility.
Okay, thanks so much, Nicolette. Kelly, I'm going to pose this question to you. Kelly, wait, I don't have audio on you.
So
There we go.
Thank you, Andrew. So as an emergency manager, it's really everything is a partnership with us. We don't have we are not in an organization chart with solid lines from our box to other boxes. We are a dotted line to everyone, internally and externally, and so it's about partnerships. It's about meta leadership. It's about value. You know, what is a partnership? A partnership is two or more entities or individuals where the relationship between them creates value for each, right? And so that's really our mandate, is how do we create value for all these people that we're connected to, and that's what we strive to do here. You know, I would say our number one most important partnership was with our chief hospital epidemiologist, right? We have a group called Infection Prevention and Control, and our epidemiologists are world-class. They all came from CDC. They saw this outbreak in Wuhan. They knew immediately what it meant for us, and they had us running from the very first day. And every single day we met with them at 7 a.m. and we talked about the virus, and we talked about what it meant. And that's where everything started. Everything we did grew out of our understanding for what the threat was and what our response to that threat should be. And so we had an op tempo that we created. We would meet with IPC at 7, and then we met internally, my team across all of our hospitals to get our act together. And then we had an enterprise call with everybody. And basically we're creating that shared situational awareness, and we're setting those incident objectives for the next operational period based on what's happening right now. And that's how that enabled us to move quickly. So you know, and we were partnered all across this enterprise, and that means that anybody that connected into the EOC, you know, we created value for them. And how do we create value? Well, what we did was we owned their problems with them, and we would go and run at the problem that we were faced with, and together we would figure out how to solve it. And usually we'd have to create task forces, which are really partnerships of different departments that have an ownership stake to really to solve the problem. And so we did that just 24/7. Externally, we had some good partnerships. You know, I've been in this business a long time in New York, so I know a lot of people, for better or worse. One of the big aspects of this incident has been fatality management, and we've been really lucky that we have a world-class office of the chief medical examiner, and they, you know, a lot of their capability grew out of 9/11 and grew out of the disasters that we've encountered. And so they've been working across the city to manage this tsunami of decedents that we've encountered. And they've got a big temporary morgue right across the street from our hospital, and we were there with them yesterday. But that partnership with us has been important to help us manage that tsunami of decedents that we have. And they work across all the hospitals. And I think if you're going to point to a model for this incident in New York, it's been what OCME has done for decedents. But it's not you can't point across the board to the government, private sector, and point to that level of coordination across all of the things that we've faced, unfortunately. And I think so. We still have a long way to go to really get to the point where I think government is doing enough to coordinate for these large-scale disasters.
All right, thank you so much, Kelly. Hey, Bob, I'm going to go ahead and move on to question number 4 and direct this one to you. This is about innovations. If you can talk to any innovations or solutions you implemented or even thought about to developing a more resilient service for your stakeholders.
I'm sorry, Laura, was that to me?
Yeah, that's you, Bob.
Okay. Well, one of the things that we did early on, I think we realized that this was not a short-term thing. So what you have, you have a race, and you have a half marathon, then you have a marathon. What comes after marathon? I haven't been able to figure that out yet, because whatever that is, that's what we're in. This goes even beyond a marathon. So realizing that the world is going to continue to turn and other things are going to happen, we kind of stepped back and we kind of took our crisis management program, and we kind of took a hybrid stance on that, and we developed a task force and some sub-task force because it is so large. The normal process could not handle, and it is actually working well. And what's even better is that since we really initiated our COVID response, we've had an earthquake in Salt Lake City, which affected our Salt Lake City distribution center. There's been some mass flooding in Canada and now in Alberta, which impacted our Innomar business up in Canada. The tornadoes and severe weather continues throughout the South and Southeast and other portions of the United States. So we still have to continue to manage through that. And now we're only a couple weeks away, or well, maybe only a couple days away from our first hurricane. So, you know, one of the things that again, we took a look at was how we were going to actually manage this, and breaking this out into the task force and the sub-task force. What the best part about that is it brought people in that normally would not be in this world or in this part of the business. And it's introducing them to it and also making them understand why it is so important for them and their departments to be prepared for something like that. So I'm very confident that our enterprise business continuity team, as they continue to work on plans and call people to the table to review plans, I think they're going to see much more coordination from those folks when it comes time to talk about their plans and reworking plans and looking at that. And I hate to keep going back to it, but again, back to the associate safety thing, one of the things that we looked at early on. Okay, what happens if we do have issues with manpower in a location? How are we going to deal with that? Well, we have hundreds of sales associates right now that are not traveling. They're not doing face-to-face meetings with customers. So what are they doing? Well, they learned how to pick, pack, and ship. So if we had to find, you know, the second team or some bench help in our pick, pack, and ship operations, we could turn to them and bring them into the pick, pack, and ship operations into our distribution centers, and they could help fulfill orders and get those orders out the door. Same way with our administrative associates. Again, many of them are not able to work from home. Their positions just don't have a work from home part. So what we've done is we've taken some of those who were sitting idle and brought them in to train and to support our order monitoring team. With the increase in orders and the increase of products, our order monitoring program has received a lot of hits because people are ordering out of their normal ordering ranges. So our order monitoring teams were just getting bombarded with order issues, and so having those additional bodies to help with those programs was great. And then lastly, working out with partners. Early on in this process, we sent out some information to our associates and we talked about PPE. Again, we're not a player in the PPE world. We have field nurses in one of our businesses that are doing home infusion. And those folks going into homes where patients are already at some level, have some level of illness, they had to be protected. Those patients had to be protected. We needed N95s. So one of our associates' husband says, well, our business, which is a welding company, we have a whole bunch of N95 masks in a box up on the rafters. We ended up buying those N95s from that welding company, and we're able to supply them to those field nurses. And it was like Christmas for those field nurses. They were so happy to get those. A welding company became one of our most important partners in COVID-19. So go figure that one.
Wow, great story.
Thanks, Bob. And Nicolette, I think you have to leave at 5. So why don't I pose this question to you and then we'll move on to Kelly.
Sure. One of the things that we've done, we always talk about the difference between the normal supply chain and the disaster supply chain. And there are disaster solutions, donations, things of that nature that will never, ever be able to replace what the normal supply chain can do, but can provide those spot solutions. And so we actually partnered with BIO, which is the Biotechnology Innovation Organization, a trade association focused on the health industry, and produced what's called the Coronavirus Hub. The idea was we needed to make sure that there was a mechanism for members of the industry who had PPE but were not doing those normal functions of their operation to be able to donate that PPE, and we would be able to manage it in this exchange. So for example, if you're thinking about the major research and development companies in the health sector, not everybody's doing research right now, right? So they may have masks laying around. They're going to have other PPE, because as a former lab scientist, you're going to use that same PPE. And so now if it's available, we can figure out who needs it and manage that exchange. So we set that up. And within the first couple of weeks, what started as let's get everything that could be donated from the industry available so that we could start to route these things, became they're also approved buyers and brokers that have the ability to provide us with certifications, assurances, and are selling things at discounted rates. So we've been using that. It's done everything for us from get 500,000 masks from Merck that were a donation straight to New York City, but also at the same time working to do small purchases of N95s for small clinics, getting donations of masks for community hospitals, but also right now grabbing a lot of sanitizer, medical grade sanitizer has been a big one. So that's been an innovation that we used, and it's outside of some of those other tools that are intended to be large procurements for health systems. We partner with those folks, but this has really started to be kind of thinking about those folks that would not have the same type of buying power and could benefit from those small donations.
Nicolette, is this the hub for members or anyone?
Anyone. It's, I want to say it is hub.bio.org. I'll put it in the chat.
Okay, thank you so much.
No problem.
Hey, Kelly, what about you?
So there's a phrase, necessity is the mother of invention, right? And so we have had necessity, we've had the need to innovate, and so you know, it's a couple minutes before 5. I could start now, and you know, this time tomorrow I could still be talking to you about that, but you know, I'll just hit on a few highlights. I mean, you know, everything changed for us. Everything. And one of the things we did very early on, and all hospitals did, was we essentially banned visitors, right? So family members could no longer come in, and so that required a lot of innovations. Everything from you know, iPads on a stick so that family members can talk to their loved ones who are patients, to what we call a Family Connect program, where we recruited doctors, we recruited fourth-year medical students who partnered with our hospitalist. The hospitalist is really the doctor who cares for the patient in-house, in the hospital. And so, you know, if you're in the hospital in a typical, you know, in a blue sky environment, you know, the family is there and they wait for the doctor and they talk to the doctor about what's going on. And of course, that was not possible. And so what happened was that this Family Connect team got together, and they developed a workflow, yet another workflow, so that they could partner with the hospitalist to understand the situation with the patient. What was the diagnosis? What's the treatment? You know, where is the patient right now in you know, in the course of their treatment? And then they would connect with the families. They would call the families, and they would be available to the families. So it became this liaison from the hospitalist to the families, and it was hugely important, especially if there were patients who were dying, you know, for instance. And so that Family Connect program, it has a lot of different aspects to it, but it didn't exist. It wasn't even an idea in anybody's mind 2 months ago. And but you know, in January of this year, we had a virtual urgent care program where you could get a virtual appointment with an emergency room doctor, and they did about 60 visits a day. Today we do 650 visits a day. We have 400 doctors' offices and that closed essentially, and so within a week and a half we were doing 4,000 virtual physician visits per day in this, across our organization.
Wow.
We had a situation, you know, with our PPE, obviously, and one of the ways you protect an N95 is with a face shield. And face shields became a critically short supply. So you know, we convene a group of academic medical centers, the emergency managers there, and one of them was building face shields from office supplies. So overnight, we called Staples, we tortured Staples, absolutely tortured them. They went to every warehouse within 100 miles, and we had them driving. We had the executives, you know, throwing office supplies in their trunk at midnight, driving these office supplies to us. And by, you know, 2 days later, we were building 1,200 face shields a day using medical students. So that's the kind of thing that you do in a job, right? You run at the problem, and you just don't take no for an answer. I mean, you know, Staples is a great partner of ours. Can you imagine how much business they do with us? But you know, when they said, look, well, you can have it Monday, we said, no, we need it today, like today. And they were like, we can't do it today. We said, why not? And they said, well, blah, blah, blah. And we said, you know, throw it in your trunk and I'll pick it up in the front of my hospital. You know, you're 40 minutes away, so, you know, I'll give you an hour. You know, what are you going to do? And so, you know, that's really, you know, rule number one is you break all the rules. Just as simple as that, right?
I know you're from the Midwest, but you are now a true New Yorker. You beg, you borrow, you steal, you torture, whatever you need to do to get the job done. I love it.
Yeah, you know, you learn, you know, by living here. That's how you get things done, right?
That's right. For you. Nicolette, I'm glad to see you're still on the call. Our next question deals with planning, and what's next?
Sure. I will take this, and then unfortunately I do have to drop, but I'm going to try to join the next one for sure. Planning. So from my vantage point, I think all of us have had solid plans. The thing that, you know, Bob's heard me say a few million times, we don't have plans for what happens when things happen at the same time. And that's I think the new phase of this is, what does it look like to deal with COVID and hurricane season? COVID and the wildfires that are happening in Florida right now. And what does that mean for everything from mass care to supply chain movement to types of supplies that we may need to prioritize? How do we prepare for the upcoming flu season, that sort of thing. This is normally the time where we would be preparing for flu season. We're a little busy right now. So what does it mean to be able to deal with these converging events? So I think that is a big part of this for me. There's not a day in the last 3 weeks that I've not thought about the hurricane season that is rapidly approaching and what it looks like to be continuing to deal with this response in the midst of that. I think it's also going to be, and I think this is a conversation for another time, but there's also going to be a conversation, I think, about what it looks like to deal with resilience planning. And, you know, Kelly touched on it as it relates to like the coordination with the government, what we need from the government. And part of that is like the S&S versus what's going to be expected of the private sector, what types of partnerships need to be in play, what types of products are we going to see go back into the stockpile or stockpiling strategies for future events like this. So that's kind of where we are on this, is thinking about how the actual playbooks and plans deal with multiple events, but also thinking a little bit further ahead and saying, well, we now have some vulnerabilities because we've had to spend the last few months focused on this. So how do we deal with closing those gaps as it relates to being protected for other types of hazards, and the coordination that we'll need to make sure is in place with the government for that to happen.
Okay, Nicolette, I know you got to jump, but I just want to say thank you for all you do and for being here today. I really appreciate your time.
Thank you. Thank you for having
Ditto.
me.
Thanks, Nicolette.
Thank you.
All right.
Bob, I know you touched on planning when you talked about staff and cross-training and staff safety. Is there anything you want to add to how your firm is planning for the weeks ahead?
Well, sure. And it's not number one, but first on my list I have is reconstitution or reentry. What does that look like? Next June of 2029, we are planning on opening our new corporate headquarters just outside of Philadelphia here. That building is taking 5 separate buildings here in the area and combining it into one. But what does that do to the design of that building? Do we need to go back in and take a look at redesigning that building?
Yeah,
Like,
yeah.
For social distancing and other stuff.
Right, even that entryway that you talked about where you can take the temperature, maybe you have a
Yes.
dual, yeah. So,
How does that go? We're going to maybe have to go out and hire our own nurses to be full-time standing at doors, or the appropriate training, probably not, but we'll have to look at that. Sales is a big part of our business. We have to sell it before we can ship it. Sales has always been a handshake and a face-to-face. That may no longer be. How is that going to impact our business going forward? I can't be quoted on the number, but I'm just going to say every day on a normal business day, we probably have 120 people in the air going somewhere. That might not be the case anymore. We've always been a heavy person-to-person company. Nicolette touched on it a little bit. Looking at our pandemic plans, our enterprise business continuity team right now is working with all of our business units on what we're calling phase 2 of the pandemic plan, working your pandemic during another emergency or crisis. Here, I'm sitting in my office today because I've got my team and our watch center downstairs going. So I still come into the office every day, but the majority of our people are working from home. If our power goes out here in this building, the generator kicks in, 3 seconds later, we're back to work. What happens when over 70% of our associates are working from a source that does not have backup power?
Right.
We have to look at that. How are we going to work through that? And the obvious one, what is the next wave? What does that consist of? I mentioned earlier, what comes after a marathon? Well, again, I don't know how many of you are planned that way, but most of our BC plans, aren't really, even if they're long-term, they're not long-term. I mean, we can withstand days, a couple weeks, but months after months of BCP, that's a challenge. And how do we continue to work through that? And then lastly, from a perspective of the pharmaceuticals, testing and vaccines, and how are we going to be a part of that as a distributor and then as a provider? Because one of our other businesses at AmerisourceBergen is the Good Neighbor Pharmacy. That is a good pharmacy, a local community pharmacy network. And how can we be a part of that, the testing and the vaccine process? Something that we want to be a part of as well. That's just some of the things that are.
That's enough. Thanks, Bob. Kelly, same question.
Yeah, so, it's all about planning for us. One of the ways that we're doing that now is we're starting with the hospitals, and we've asked them to develop a timeline of, what just happened. How did we transform these hospitals, when that tsunami of coronavirus patients started, and we basically, we would turn a floor over a day, sometimes 2 or 3 floors over a day to coronavirus. And so what was the logic there? What did we do? How did we do it? What did we need? What equipment do we need? What supplies do we need? What personnel? What were the workflows that we executed in real time? And then so once that timeline is built, how do we turn that around? And essentially, how do we optimize it and turn it into a plan for the second wave? What did you do and when, and how do you alter that? In fact, we've already started. We've got that. We've already got both of those in place now, and we're just now finalizing that. One of the reasons is because the governor has said that we need that before we can resume normal operations. We need to demonstrate an ability to surge to 30%. We just surged to 50, so 30 is just ground ball. I don't know why we can't just turn back on again. But yeah. So and then as folks said, hurricane season is starting, and it's supposed to be a very active year. So we're paranoid. That's what they pay us for. So, but I want to go back to something you said before about innovation. I think the greatest innovation is Tom Moran's background on this webcast with the, what is that, Aruba? I mean, that's terrific, Tom. I need that. Is that because you didn't make your bed and you're in your bedroom, or what's the story there?
Yes, that's right.
No, that's so cool. Is that like an app or something? How do you do that?
No, on Zoom, if you, on Zoom, everybody's got a camera on the lower left. And if you click on the little arrow, you can select your backgrounds. They got a whole bunch of canned backgrounds. If you don't want
That's so cool.
if you don't want everybody to see what's behind you. I'm in an office, so it's not a big deal, but I just,
All right.
Apparently Kelly needs to get out more.
Boy, that is for sure.
So we may have touched on this in the previous questions, but are there any recommendations or resources that you can recommend to those on the call that they can use to improve communication and resiliency within their own organizations? Kelly, do you have anything you want to add here?
You know, the only real resource, and Tom and I I've tortured Tom with this for years, right, is the overlay of emergency management, is the role that we play in these incidents. It's essential, and but it's invisible to people because they don't get it. They're like, hey, we understand it's going to be a tough time. We're going to roll up our sleeves. We're going to get we're going to bring in some extra Starbucks, and we'll get through it. And then they're in the middle of it, and all hell is breaking loose, and they're like, what? Like, why didn't I do these things before? And so it's what we do. It's the value that we bring. That's I think the essential resource. So you can talk about planning all you want, but if you've got an emergency management overlay that's ready to connect that organization in real time and get them moving in the midst of a catastrophe, that's, to me, that's your best resource. And the reason is because there's gonna be a lot of talk about stockpiling. Believe me, I've been there. I was there. I started in this business on 9/11, right? And then we had the anthrax attacks, and we stockpiled ciprofloxacin and what was the other one? Cipro and doxycycline. And it's great. And you buy several tens of millions of dollars worth. You put it in a warehouse, and it gets old, and then people forget, and then you throw it out. And so you're never going to predict the future. You just have to have an ability to adapt. That's the best resource you can have.
yeah.
That's great.
Kelly, it's funny you say that. I was on a call recently. Somebody was trying to describe that, what the role of emergency manager, and a gentleman shared this with the group. That was great. He said emergency managers are kind of like the air traffic control tower. People barely even know they're there. You never hear about them in the news. All this stuff, but you take them away, and you got a disaster, right?
Yeah.
And they're always planning for the disaster. They're always looking. And I thought, what a great analogy, right? Air traffic control.
Yeah, it really is. I mean, you could be a platinum frequent flyer and have no idea what air traffic control does. And but you're right. The day that it goes down, then you suddenly realize.
Yeah.
So and it's like a lot of things. They do their best work if they are invisible.
Yeah.
But and that's one of the problems, is we can't articulate our value very well in a blue sky environment and when there's no disaster.
Yeah.
But I'll tell you, I think that if you ask the people around this organization, I think they would articulate our value pretty well. And that's the way it works, is all across the nation, you go to all these places where there have been a disaster. They point the finger at the emergency management agency and they say, you guys screwed it up. And then they're like, well, how do we fix it? Well, let's give them more money and build them bigger. So that they ultimately end up building them up, because they say, well, they needed to do their job. They didn't have the bandwidth. All right, so give them the bandwidth.
Right.
Bob, what about you? Do you have any last minute recommendations?
Well, just kind of looking at the question there, just some recommendations. One from a communications perspective, and it's the obvious one: be transparent. Our number 3 core value here at ABC is tell the truth and tell it fast. Early on in this process, we began and we continue to hold town halls. We held them with our associates, with our manufacturer partners, with our customers, with the feds, with state, anybody that would talk to us, we would talk to. And we were brutally honest with them in many ways. Even when we've had to shut down one of our distribution centers because we've had positive cases in there, we did not hide that fact. We told them what happened. and we told them how we dealt with it. And it has made such a difference. The open communication that we've had with all of our partners. So again, if communication, just be transparent. Be transparent. And from a resiliency standpoint, as you go through your AARs and your PIPs, nothing should be off the table. I never thought one of our most important partners would be a welding company. Nothing should be off the table at this point. At this point, I think we've all seen that just when you think you've seen it all, you haven't seen anything yet.
Yeah.
So just nothing's off the table.
Thanks, Bob. And if I can add one too, you talked a lot, Bob, about teleworking and your staff and being their #1 resource of just mental health and checking in if you have staff, if they're teleworking and they're at home all the time, just checking in that they're doing okay. All right, so great. So I wanted to say thank you to our panelists. Bob, thank you so much. Kelly, Nicolette had to leave, but so humbled by what you guys do. So and I know you're super busy, so I appreciate you time on the call. Hey, Tom, did you want to talk for a second about the SICE, and we'll move to Q&A?
Yeah, so for those that are new, you can, if you want to stay in touch with what's going on topics like this, you can register with the SICE for free. The website is on up on the screen. It's SICE, S-I-S-E, SICEUSA.org. We use that to basically build a framework for vetted individuals, so we can make sure the right people see the right information. It's been a wonderful legal framework, and it allows for, like I said before, industry to coordinate and share information that isn't going to be shared publicly, but also for the public as well. So you can register for that. Bob, Kelly, and I know Nicolette's not here. I just want to say thanks again. Kelly's right. We could talk here. You guys could go until another 12 hours. I wish, which would be great, because it's usually the conversations later in the day that become the Bob, as you said, tell the truth, tell it fast. I love that. That's really good. So anyway, Laura, that's it. I'll hand it back to you.
I just want to remind the listeners, if you have a question, to go ahead and type it into the Q&A window, which you can get to by hovering your mouse over the top of your screen. We had one or two that came in during the discussion. We have a question here, Bob. I think you talked about sterilization. How effective are the sterilization robots, and are we likely to see them deployed throughout the supply chain in places where people congregate?
Robots, we're not actually using robots. We've got people going through with backpacks and the sprayers. So I really can't speak on the robots. Not sure if they would be able to get to in a warehouse. There are a lot of nooks, a lot of crannies. How effective they would be. Unfortunately, I don't know about that. In a large open area, maybe like a break room or in the locker room area, that kind of thing, probably. But without knowing a little bit more about those, I think it's a little bit hard to necessarily speak to those. As far as the electrostatic sprayers go, things are working very well with those.
Okay, thank you. Kelly, what will your playbook contain for the future that wasn't in it before the outbreak?
Ooh, that's a good question. What would the playbook contain in the future that wasn't in the original outbreak? Too early to tell. No, I don't know. We'll replicate some of those interdepartmental groups, the asset management group, I think, and then also this core SME call that we had first thing. So if the job, for instance, is a different type of incident, right? We would have a different SME, but understanding the granular details of the incident in the first thing in the morning, and it's really working through that planning P, that you hear so much about, and I think we would just get more detailed with that process, and I don't know, I'm looking at my colleague over here, but just, and it's pretty early in the job. I mean, we're still, I think we haven't really had a chance to be too reflective yet. We're still sort of in the middle of it.
Yeah, and we had some good advice, Tom, on one of our other calls from Chris McIntosh, who just simply said, write it down. I mean, whatever happens, whether it was a mistake or, you know, something you learned,
Well,
write it down.
I made a note, Kelly, that these webinars have really brought a lot of really operational people to the table, right? And Laura and I have been taking notes like that, and one of them could be a really good one is kind of an operational discussion. What are your takeaways? You know, and we could write that down. We just want you to talk, right? We just want you and Bob and Nicolette. So that's part of it, because one disaster goes right into the next, right? I'll give you a case in point. We're tracking 3 different technologies we heard about on phone calls. One of them is very promising. It's we heard this on a CISA call. It's a company that one of the gentlemen from New Jersey owns a bus company. Bus company went out of business, but he has to clean these buses. So he found out about this company in Texas that makes this device. Again, this is all, we're validating all this, that buses and rooms and planes, and you know, it combines hydrogen peroxide with oxygen and creates this mist that's safe for humans and everything else. Anyway, big claims. We got the data sheet, but we're tracking that. The DOD's analyzing it right now, so we're waiting for that report. But we learned all that on calls like this, right? They're trying to get DHS to help them, and I thought, you know, like you said, Bob, you know, tell the truth, tell it now, because we're not going to wait a year for this. If this is something that works, we want to find it and get it out there to the private sector. So all kinds of things are coming out of this that we think we can all benefit from going forward. So.
And you talked about the series, Tom. So we have a couple coming up. One on Tuesday on sensitive information sharing. And then we are going to have one on donations management in early June. And we're always working on these. So, you know, just, you're on our list. We'll send you the information. And I also wanted to give everyone my email address. If you have any questions, if you have an idea for your own virtual discussion, anything that we can help you with, reach out to us. And I went ahead and I unmuted everyone's phone, or I hit allow to talk. So if you want to unmute your phone and say hello, that'd be great. Matt Loxton, if you're there, you had posted an interesting comment in the chat. We'd love to hear from you. You there, Matt? So he says in his chat, I'm gearing up for an appreciative inquiry study on what worked best during the COVID response to help get ready for the next wave. And he put a blog link in the chat to the panelists.
Yeah. Hey, Laura, I have a question, Bob and Kelly. Kelly, what information would be helpful from your perspective right now for you all? What types of things, thoughts, resources, information that when we could apply our energy to that assist folks in your position, Kelly? And then Bob, I'll come to you as well.
Well, you know, for me, you know, you know, as an emergency manager, for me, it's all about coordination. It's all about breaking silo walls down. And so how do you do that? Well, you do it up front because you can't do it in the job because everybody's too busy. And so we break those walls down here, and we show a process about how we're going to work in a job, and then we work it in a job, and people are like, oh yeah, I that looks familiar because you told me you were going to do that. And I think the biggest silo wall problem that we have as a nation is this government to private sector gap that we have. And you know, that is the one that we saw that in this job. I mean, there were so many people working on this incident, but they weren't working together. They were working. They all thought they were working together, but they weren't. The gap was there, and they weren't working together. So I think it's really, Tom, about what information is really like, how are we going to, what's the process for how we're going to work together more effectively, you know, in the job. And because you know, we work with private sector partners, and we, you know, in the supply chain was all about private sector, but the government was involved, but the government was working, you know, simultaneously, in some ways, at cross purposes to what we were doing. And so that's a great example. How are we going to fix that, Tom? How are we going to fix this thing where government isn't trying to buy the same things we're trying to buy, so that we're competing against each other instead of working together? And
Yeah.
you know, I guess that's the thought I had.
Okay, Bob?
Well, for me personally, one of the things really, and I don't know it's really directed to this group or not, but it is around information. And I'll just, you know, having the Johns Hopkins map and all of that information is great, but now there's 20 other sources that have that. It's pretty much the same, but yet it's not. A couple weeks ago, I started tracking before all the stay-at-home orders started to expire, and you know, who was doing what. That information was somewhat scarce. Now we've got 20 different sources of information. So having everyone understand that information is good. Good information is great, but having it in 20 different places, maybe not so much. So it's getting that reliable source. And I'm not saying that, you know, one person or one group should be responsible for all of that. But I did find that to be a little bit frustrating from an information perspective, trying to find that. And initially, I think the only place I found it was in a New York Times article of the tracking of the stay-at-home orders. And now, like I said, now all of a sudden, everywhere you turn around, somebody has that information in a different format or a different source.
Yeah.
So, and we don't know what we don't know, but we know now we need to have something, and we need to find that information quickly. Having the ability to do that goes a long way.
Okay, excellent. Thank you. Laura, any other questions we have?
That's all the questions that we have. So unless anyone on the phone or on the line has any other comments, last minute comments, or wants to say hello.